Thank you so much for having me here today. It's a really kind introduction, and it could not be better to be in Phoenix in December. So I just wanted to say that's a wonderful place to be here today. So thank you all very much. My name is Stephen Smith, and I'm the co-founder and CEO of NOCD. And so we are the largest provider of online therapy for people with OCD-related conditions. And we have been able to grow over the years thanks to the support of many different providers and payers in the community. In total, we have about 155 million commercial lives on our contract today, and we serve nationally in all 50 states, as well as internationally in 3 different countries. And the experience has been, honestly one that is personal for me, where I'll get to this in a second, but I have OCD and went through the ringer with it. And so I come from a patient's perspective today. I know there are many clinicians in the audience, and I have a tremendous amount of respect for what you all do, and I see the rigor in your work every day, and personally see it through Dr. Jamie Fiesner, our Chief Medical Officer, who's in the room today. But it's a really personal but yet important mission, and I think one that we can all towards the end of this presentation really lean on. And so the goal for today is to first and foremost present about maybe 15, 20 minutes or so just about the population OCD and some of the learnings that we've had. And so just as a disclosure, again, I'm the co-founder and CEO of NOCD, so there'll be some elements of what we've done embedded into the presentation. And then after the first initial presentation, I'm hoping to open it up for Q&A, just because we all learn, I think, in a more engaged environment. And I think sometimes having a Q&A that involves just open dialogue really makes the session fun and also really informative. So without further ado, I'd love to introduce some of my background. So as mentioned, I actually have OCD, and OCD is a condition that affects roughly 2 to 3% of the global population at some point in their life. And it's a condition that almost everyone recognizes, and yet almost everyone misunderstands. It's a very unique term in that way, where you may walk down the street and hear someone say, I'm so OCD. And someone that they're talking to may say, I understand that I'm a little OCD myself, but at the same time, both people just truly don't understand what that means. So they're using a term casually, which they just don't understand. So it's very strange that you have that phenomenon here in the 21st century. So I oftentimes think about that. Well, that misunderstanding personally, unfortunately, led me to a point where I went from literally the starting quarterback at my university, I was at a small school in Texas, down to rock bottom in a span of 6 months. And so when I went home for summer break after my sophomore year of college, I started having the hallmark intrusive thoughts that are associated with OCD. So I had thoughts that I was very embarrassed about. They contradicted my core values and character, and they created a tremendous amount of distress for me. And to try to make them stop, I would do different actions, not just actions that were visible, but also actions that were in my head. For instance, I would go and I'd reassure myself mentally. I would review past events in my head. I would also, at times, search for reassurance via Google. I'd try to Google search my fears in the hope that one day I'd find an answer that would disprove my thought, and it would ultimately lead to less anxiety. At the same time, I would ask for reassurance with my different family members. So I would ask my family members to disprove my fears in hopes that they would, again, alleviate the distress and the thought. And so after a certain point of time, I started having so much distress consistently that I went to see a provider. I didn't know much about the mental health care system. I just said, look, I'm suffering a lot. I'm embarrassed by what's going on. I need to see someone who can help me. And so I went to a provider in the northern suburbs of Chicago that was backed by my insurance plan. And the provider told me, look, you're just having anxiety. For every time you have a thought, I want you to take a rubber band around your wrist. I want you to snap it several times, because that might be a way to remind yourself that you're in fact just having an irrational fear. So I literally started doing that, and as many of us will probably understand, I started getting worse because of it. So then I saw a second provider, and they said, I want you to imagine that a train is running through your head. And every time you have one of those fears, I want you to take the fear and I want you to place it in one of the train cars and let the train just go on by. And I was like, wow, that's kind of strange. But I'll go and do it because I think you're an expert and I'm just a patient. So I started doing that, and of course ended up getting worse. Saw a third provider shortly after that, and they said, you should just move away from your family. I think your family is the root of this after just evaluating your background. If you go home to South Texas, I was in Chicago. I was I was with my immediate family, and I was living in South Texas at the time. He said, if you go back to South Texas, you will all of a sudden have an alleviation of the distress. Your fears will go away, and everything will get back to normal. So packed my bags, drove 1,500 miles down to Texas. Eventually, then at that point, it became so severe that I started having depression. I was like, I can't even function. I can't do the things that I love. I can't engage in my relationships. I don't know what to do. I just became extremely depressed. And that's when I became housebound. And when I was housebound, I went to try to find another provider, and they said, you're just really depressed. Let's treat the depression. They didn't address the root issue. And then eventually was out of school. I was suffering from the time I woke up until the time I went to sleep. And I was honestly pretty much crippled. I couldn't do anything, and it was in a very, very dark place, like many people with OCD when they're going through the ringer. And then one day out of desperation, as I was searching my fears, I stumbled upon a group of other people who were going through the exact same thing as me, and they defined their symptoms as OCD. And I was like, wait a second here, OCD? I thought that was just a personality quirk. I had no idea it was such a prevalent but yet severe psychiatric condition, and it manifested in the ways that we described earlier, which is, recurring unwanted intrusive thoughts, images, and urges paired with actions to try to make the thoughts stop. And they were going through their symptoms and their journey in a very nuanced way, and they were defining exactly what I was going through. I was like, wait a sec, I had no idea there were other people out there. That's almost like a parallel to my experience. What do I now do? And as I started researching more, I realized I did have some symptoms, but again, I'm just a person. I'm not a clinician. I needed to get a formal diagnostic. And so I tried to find a specialist in my area that did evidence-based treatment for OCD called exposure and response prevention therapy. And even I tried to get an appointment with a psychiatrist, hoping that they would at least give me the assessment. I couldn't find one. And this was in 2013. And so at that point, I was like, well, what am I going to do? So I went to the ERP specialist. She was cash pay. She charged $350 out of pocket per session. She had nearly a 2-year-long wait list. And she said, if you want to try to get better, at least here's some self-help tools or self-help books at the time, and those self-help books will hopefully be enough for you just to at least get started. And so I waited on the wait list. Fortunately, a family friend came in, covered the cost of my care. I ended up getting to that provider, and she said, look, you're going through a hallmark case of OCD. A lot of the taboo, intrusive thoughts manifested in like the relationship subtypes, the sexual intrusive thoughts, the contamination fears in some capacity, just many different types of subtypes that were less talked about but very common. And then she said, you're going to do ERP therapy, and we're going to work together on these specific fears, and eventually, you're going to figure out a way to regain your life. And with that support, that's exactly what happened. So I started doing ERP therapy. I was learning how to resist doing not just the physical compulsions, but also the mental compulsions, which many people forget about. And then slowly but surely, day by day, started getting better to the point where I was able to go back to school. I went to a small school in Southern California called Pomona College. I was able to finish up my degree, and I was able to finish up playing football, and I was pretty much back at the same point where I was prior to my onset of OCD. And that's when the light bulb really went off. And I realized that, 1 in 40 people globally have this issue. It's a very common problem. But yet at the same time, from doing further research, 96% of the OCD population does not surface in claims data, meaning that most people are actually not getting the proper diagnosis earlier on in their journey, just like how I was. I was fortunate where, for me, my suffering was kind of only over maybe a year at most before getting a formal diagnosis. After further research, it was realized that it's actually 14 to 17 years for most people on average before they get access to an evidence-based treatment for OCD. And that's shocking in today's society. Like, you have one of the most common severe but yet treatable psychiatric conditions, and there's just really not the infrastructure in place to truly affect the population and treat the population. And so when breaking down that problem, I realized it was because of 3 specific things. First, there's a widespread misunderstanding about OCD, right? Where people, again, have that common perception that OCD is just a personality quirk. But even like I did before getting a formal diagnosis. And what that does is that creates a situation where patients, people with the issue, they don't realize kind of what's going on, and they feel very uncomfortable disclosing the specific symptoms that they're going through. right? So if someone has OCD, and let's use an example, a mother with a newborn child, or let's say someone who's at work, if they have a violent intrusive thought about another person they're working with, all of a sudden they're going to be viewed as a monster if they go into that doctor's office and the person doesn't understand them. So what they say instead is, hey, you know what, I just have anxiety. They talk about the symptom, but not with the issue driving it. So you have the problem where people don't understand the problem, the issue, and then they end up disclosing the symptoms, not the root problem. At the same time, providers often aren't screening for OCD. They're not asking the questions. And many of them are a little bit misinformed about what the OCD symptoms are really like. They may understand the hallmark symptoms because that's what they're trained on, but not trained on the full spectrum of symptoms. And so what that does is that creates a situation then where that misunderstanding leads to misdiagnosis, where you have the problem where 96% of people with OCD do not surface in claims data. So it's an issue that when there's misunderstood, they're misdiagnosed, there's a miscoding element involved with it. And when they get misdiagnosed, then what happens is they get mistreated. And like I personally lived this. You get oftentimes treated for not OCD, but potentially the symptoms that emerge or the comorbidities that develop because of OCD going untreated. And sometimes those treatments aren't just ineffective, they're actually harmful. So people go to treatment thinking they're going to get better, and unfortunately what ends up occurring is they don't just not get better, they get worse. And if you think about that, that's happening widespread today across the country. And so as I started to think about that problem, I was like, look, this is not a clinical issue. This is an operational issue, and it's an ethical issue. How do we have a situation today where 1 in 40 people are spiraling in the system because of this just broken nature? Like, we could do something about this. And that was the catalyst for starting NOCD, because I realized, look, there's a way you can solve this problem with technology, but I also think there are other ways in which you can solve it. And that's one of the areas which I'm hoping to discuss here today. So first, there's ways that we could solve at the top of the funnel with better understanding, right? Providers that are, especially those that are equipped to see large volumes of patients, prescribers as an example, you know, there's many people on your panel, right? And if you think about it, 1 in 40 people have OCD, and we've learned over the years it's about 10% of a panel for a specific behavioral health prescriber at times. And so if there's an opportunity to screen at the top of the funnel, what that will do is that'll uncover people with OCD symptoms. Not all people will actually they'll meet the full diagnostic criteria, but at least enough will be surfaced where they actually may meet the diagnostic criteria and may then, be able to get specialty treatment. And then second, once we identify more effectively, we can use the evidence-based instruments to truly assess for people with OCD. That's an area of focus for us at NOCD. We've also worked with many partners in the community today who are doing the same thing. But getting that proper assessment could be the difference in getting evidence-based treatment early on, or potentially getting that evidence-based treatment in a couple decades, right? And that's someone's life, right? And it's I can tell you from personal experience, the amount of suffering that happens when you're not assessed and treated effectively is grueling. You don't want to go through it. And then third is, once you finally get diagnosed, then it's about getting treatment. And so what we've seen as we've navigated the landscape and grown the company, we have about 700 providers in 50 states. We do about 60,000 to 100,000 therapy sessions a month in OCD. What we've seen is that there's a number of providers that can either properly administer medication and manage medication, and second, there are providers that can truly provide ERP therapy, and they have to work together as one team. But it's difficult to do that, right? And so it takes extra work. And so we really have to then, once someone's diagnosed, effectively use care coordination to ensure that, one, prescribers are prescribing medication in an effective and an accurate manner. And then second, providers who are delivering ERP therapy can do so in a seamless manner and can also scale to reach the population in need. And we've seen, too, that if we can solve this problem, there's actual tangible benefit to the overall healthcare system. So this isn't just an opportunity to do good for patients. It's also an opportunity to do well for the system and to then be able to acquire the resources needed to reinvest back in and truly solve a large percentage of the mental health crisis. And so here's some of the data that we have been able to uncover over the last handful of years or so. We've seen that when someone gets access to the right care at the right time at the right place with OCD, then they'll be able to not just get better faster, but also they'll use the healthcare system less. From a behavioral health side, that means they're no longer using residential services at the same frequency level, right? They're not going from provider to provider, then eventually into an IOP, PHP, or even residential center. So when someone gets better earlier, not only can they go in and live healthier and engage in their life, but also then the costs that would have occurred because of their unhealthiness don't happen, and then that can alleviate burden on the system. At the same time, when people with OCD get severe, they not only develop severe comorbidities, they also sometimes will compulsively use the healthcare system electively. So for instance, someone may have a health concern and they may end up going and getting elective MRI done, or they may go to the ER to try to disprove a fear that they're having. And so if you can treat them earlier in the journey, what ends up happening is there are less costs overall. We actually proved this with a very large commercial health plan on a several-year study. And we showed in total the overall savings, both behavioral health and medical, was roughly 567 PMPM, which means that on a monthly basis per member, it's $567 were saved. And so if you think about that across a widespread population, that's a tremendous savings potential, which again, those savings are then able to be reinvested back into the system if needed to help more people in need. And so we think about this because if you solve an operational issue like as widespread as OCD, what ends up happening is you gain the leverage needed to then get the resources to help more people. And I think that's the way in which the 21st century of mental health care should be thinking. We're showing clinical impact and economic impact to then better the patient experience and help more people in need earlier in their journey. And so, when we think about what does that even mean? Like, what are the takeaways, right? How do I even get started? I typically go to three things. First, screen for OCD. So it takes effort, right? But with just two questions to ask about obsessions and compulsions and ask about specific intrusive thoughts, you could eventually uncover people who exhibit symptoms who otherwise would never have shared those with you. Right? They're too embarrassed typically. Again, think about the mother with a newborn child who fears, what if I'm going to harm my child? She's not going to go and talk about that publicly to her PCP. She's only going to do that if she's comfortable and if she's asked a very direct question. So you have to build rapport. You have to ask the right questions. And then second is identify OCD specialist therapists for prescribers in the room. We know that there's a care coordination effect that's really important. The gold standard treatment is exposure response prevention therapy plus SSRI medication. So it's critical to have specialist therapists that you can work alongside with to make a great clinical impact together. And then third is track patient outcomes. And we know a measurement-based care approach is truly imperative if you go and you want to show clinical and economic impact, which then can lead to more resources, which then can lead to a larger way to help more people, right? That's how we've seen scale at NOCD. We've realized that if you can measure what you're doing really well and you can show the clinical impact, then you could acquire the resources needed then to reinvest back into the system and ultimately help more people in need. And that's what's needed today, especially in very severe, high-cost yet treatable populations like OCD. So I'm sharing this with you because we're kind of at a crossroads with the overall mental health care challenge. Like, we've focused for the first handful of years, if you think about the past handful of years, on just providing access, right? We've really realized that, look, if we get people access to care, they're going to get better. But now we're starting to see a change where it's not just access, it's about the right access. And to get the right access, I believe fundamentally that you have to do those three things. We've seen them across time at NOCD, and we think those are three things that could really help the community. So that's my 15-minute overview. And I want to make sure we can get back to the we can get into a Q&A. But I would love to just thank you again for listening, and I'd be happy to answer any questions that you might have here.
Anyone want to start?
Yes, sir.
Thank you. That was a great talk, and certainly thank you for being vulnerable, sharing your experience, right? Can you talk a little bit more about the model and sort of how you interact with payers and the delivery and how people access care and all of that?
Sure. So for the NOCD model. So the NOCD model, the way it works is at the fundamental level, people come in, they do live face-to-face sessions with our licensed therapists who are all specially trained, and they have to actually test into our network. And then when they do those sessions, they're all video-based. They can get access to their provider. Then between sessions, people have access to always-on support, such as asynchronous messaging with their therapist or even a member advocate, different peer communities, different self-help tools, live support groups, so a variety of different services. The clinical model, the way it works is people do twice weekly sessions typically, and then once they, based off their outcomes, once they show some progress, they step down to once weekly sessions, and then eventually they step down into a maintenance phase if they can show a clinically significant reduction in severity where it's about, on average, a one session a month. And so we try to have a step-down approach that it's 100% virtual, and we've tracked outcomes. The way we work with payers is we work with payers as a specialty provider, where they look at us as a center of excellence for OCD and related conditions, and we serve their population. The challenge, though, is how do you reach the OCD population, right? So at the front end, what we do is we run what we call our community campaigns. So we create content that speaks to the core symptoms people with OCD have to navigate, oftentimes alone. And when we speak to their symptoms, then they realize, wow, I'm not alone. Let me go and connect with others that are like me in the NOCD community. And so then they connect with others. They learn more about the condition. They'll at that point realize that they need to get access to evidence-based treatment. And they come into NOCD therapy after that epiphany. When they're in NOCD therapy, about 50% of our members are on medication, just knowing that the gold standard is OCD as well as the gold standard for OCD is ERP plus SSRI medication. And so we don't actually provide medication, we refer out because we want to make sure that our members can get access to different preferred providers, and those preferred providers are vetted by our team. So that's our model. Payers know, though, that we can help them manage their population and then ultimately allow people to get access to evidence-based treatment faster. And so just to give you some of the statistics behind what we've done, when I was going through treatment, there was a $350 an hour. You have to wait 2 years on a wait list. If you were able to get in and pay for it, you could potentially get better. But when you're between sessions, you're often on your own. We have been able to show that now 1 in 2 Americans can get access to evidence-based OCD treatment as a covered benefit. They can get into treatment within 7 days on average, and between sessions, they're never alone. They have access to all these different support tools in between. So it's a better treatment experience. And I think that's not to promote NOCD, that's just really a model that we believe can be used across the ecosystem, right? Where if you think about it, like we need to figure out ways to identify folks in a more patient-centric manner. We have to find ways to build trust with them, to get them to take their first steps into care once they're identified. And then we need to find a better way to treat them that's kind of a hybrid of tech and touch. Not just tech, not just touch, but a hybrid. And that hybrid changes depending on where you are in your patient, in your treatment journey. So yes, that's how we work with payers, and it's a always evolving process. Yeah. Thanks for the question.
Thank you. How do you handle comorbidities? So as you mentioned, depression is a common comorbidity, but substance use and others as well. Do you deal with that in-house, or do you refer out for that?
It depends on the comorbidity. We've seen that some patients, after getting a formal diagnostic assessment, they end up getting better with a focused treatment to their OCD. For instance, if someone has OCD, anxiety, depression, stress, if they get, in some cases, if they get access to ERP therapy, then what ends up happening over time is not only does their OCD symptom severity decrease, but also so do their comorbidity symptoms, or comorbid symptoms. So that's in some cases. In other cases, if someone has a complex comorbidity that we can't manage, we will actually refer out and care coordinate with a specific provider. What we're starting to do, though, is we're starting to build different segments into our network where we'll have additional trainings in not just OCD, but some of the comorbidities. For instance, we have a large population of people who have BFRBs. We have a segment of our network that has habit reversal training. We also have a population that has PTSD, and so we have a segment of our network that has deep training and prolonged exposure therapy. And so we're starting to segment as well. But I think the takeaway is, there's two ways to really handle it. You can train internally or refer out, and we've really tried to keep focused on what we treat in-house while for those who are not necessarily a good fit for an OCD therapy, they'll refer out. Yeah. Thanks.
Thank you. Two questions. One is, what is the therapist experience like with the being available via the text messaging in the app? And do any therapists complain about burden related to that and the time it takes? And the second question has to do with the cost savings and whether you've itemized where that savings comes from within the model.
Yeah, thank you. So to answer the first question, between sessions, therapists can respond to members at least once per day within a 24-hour window, so we make that expectation very clear up front. We also reimburse therapists for that time. So as the provider, we will reimburse our therapists for that time so that they have that. Second is with the cost savings. We've shown that the savings from the behavioral health side, they come from two places. First, we actually can get people better faster. So when you get access to evidence-based treatment, in let's say 14 to 20 hours of therapy time, you don't then need to do 1 hour therapy sessions every month for years on end. It's a step-down model, and we can actually deliver treatment in a more efficient manner. We've been able to prove that because it's a tech and touch approach. So that's one element of the savings. The second element of the savings on the behavioral health side, I use behavioral health and medical because they looked at two different buckets, was on reduction in RTC utilization. So if people get the right care at the right time at the right place with OCD, they don't then oftentimes need to go to higher forms of care. And alternatively, if they don't, then they often will end up in a higher form of care just given the severity. And so getting that diagnosis right early on in the journey and then getting them connected to evidence-based treatment, that will lead to the reduction in higher forms of care. And I think in the study, there were 400 patients roughly that were analyzed, and you typically would see out of the 400, 10% go to higher forms of care. This is from the behavioral health medical director's data. In our sample, there was only one that went to higher forms of care, and that's simply because of the fact that they were able to get treatment earlier in a way that was evidence-based. And so that's on the behavioral health side. On the medical side, it was a reduction in the additional procedures. So for instance, someone would go use a healthcare system compulsively. They would go to the ER, they would go to different clinics to get different MRI services done or CAT scans done, and to disprove their fears. And then when it didn't work, they'd go back a second, third, fourth, fifth time. And so we were able to show that if you were able to get those patients better faster, then they wouldn't use the healthcare system in an elective way and generate tremendous amounts of cost. So that was on the medical side. In addition, there were patients who developed severe comorbidities related to substance use disorders, and also other medical, other complex behavioral health issues, and then those patients would go to the ER and whatnot without having that happen because they got care earlier on in the journey. Those costs never incurred. So that was how we looked at the data. There's more analysis to be done, though. So, yeah.
Thank you.
Yeah.
Thank you, Mr. Smith. Okay, a couple of questions. I wonder if you could go to that first slide that sort of shows your timeline. While you're there it is. I also wanted to know if it's possible that you have underestimated the number of patients with this disorder, in that you sought help from a non-network provider that wasn't counted, and others, I guess, are like that too, or it takes so long to be diagnosed. Is it possible that there are more people than are actually counted with this disorder?
Definitely, and I know actually our chief medical officer, Dr. Fiesner, did a study where we analyzed the types of patients that engage in our community, right? So we have one of the entry points into the NOCD ecosystem is we have this community where people anonymously can talk to others, post questions and whatnot. And it goes to your question because what we found in the community was that most people actually suffered from some of the more hard to talk about OCD symptoms, right? Where they talk about their harm-based intrusive thoughts, or sexual intrusive thoughts, or religious intrusive thoughts that you typically, or we showed were actually maybe more common than one would have thought, where research suggested earlier. And why that's important is those are the patients who get missed. And so when you think about some of the research that's been done in the past, if the research has been done and it's also missed those patients, then you think, okay, well, maybe the prevalence could be higher. It hasn't been proven yet, but there are many people who believe that it actually might be a little bit higher than that 2 to 3%. It just hasn't been proven. We've seen, though, as we've grown, tremendous volume in their community, which makes us believe personally that it is higher. But it's just we haven't proven that via research yet.
Curious about the inflection point here, and what may have caused that inflection point, because it's before you see provider number 5. So
Right.
I'm wondering what was going on with some self-education or something along those lines.
That inflection point, great question. That inflection point was when I was searching online and I stumbled upon a feed. It was kind of like Reddit or Quora, where people were talking about the exact symptoms I was experiencing. And that what it did was it made me realize that, wow, there are other people out there with a parallel journey, and they were defining their symptoms as OCD, and I had no idea about OCD. And so then at that point, I was like, wow, there's someone else who's going through this exact same thing. They're defining their symptoms as OCD. I better learn about this. So I started researching more about OCD, becoming more aware about the common symptoms and reading about it. It almost felt like a hand in glove. It was exactly, from a symptom stance, what I felt like I was experiencing. And that's what encouraged me to take steps to go and try to find somebody who specialized in exposure and response prevention therapy. And so that's the inflection, right? And at that point, I ran into more challenges. Our goal has been to remove challenges, one by one within the system, so that people don't have to, wait on a 2-year-long wait list and pay $400 almost out of pocket per hour, right? And so that inflection point, though, was that psychoeducation component, and that could honestly have been, that inflection point could have happened earlier in the journey if my provider, number one, did a common screener. Like, they heard the symptoms and they did a common screener that said, okay, do you at least screen positive for OCD? And there are screeners out there today that are widely used. We're not seeing them. They just haven't been disseminated, frankly, at a large enough scale. And part of the reason why we believe that's the case is because it takes time, and time is a function of reimbursement, right? And so if people or providers aren't getting reimbursed in a more or in a larger manner for that time, then they're not going to utilize the tool. That's one of our learnings. So we think that over time, if there's incentive to screen, it could actually solve a lot of this issue.
So it's nice to have a screener. I agree with you. And another issue is also identify the people that will respond to the therapy, because it's possible that some of them will be treatment resistant to your specific therapy. I was wondering if you have any tools that actually can predict treatment response to your tool, and if, I'm assuming that you don't have it, but do you have a way to actually recommend to other therapists, like other forms of therapy like TMS or anything else that might work in these patients?
It's a great question. That's an area we're actually working on right now. So we're working on ways to predict treatment responders and non-treatment responders using some machine learning models. We're also, when someone fails the first line intervention, we're working on finding different providers that could help with second, third, fourth line interventions. And we typically refer out in those moments, right? Sometimes people get referred into higher forms of care where they'll go to McLean, they'll go to Rogers in certain states. Other times we'll refer them to places where they could potentially engage in TMS and whatnot. But it's an opportunity for sure. And our goal has been, let's get the base layer figured out. Let's really ensure that we can build a new front door to the treatment system for people with OCD-related conditions. And then second, let's have the right access nationally in a way that's effective, affordable, and convenient for people. And once that's down, we can then go and build up from there. Yeah. Sir.
Hi, great talk. So I remember the first part of your talk. You said, you were trying to figure out how to pay for the treatment you ended up getting, and so I was thinking of two things. One is, around the world, a lot of therapists aren't trained in exposure therapy. They don't even know it exists. I'm from Argentina. There's a lot of psychoanalysis, and they're not trained in it like the psychodynamic therapists are here. So are you thinking of ways to provide, your first scenario was you might not be able to afford it even if it did exist. What are some options for those folks? Have you thought of this? Or for, countries where even if they could afford it, there isn't training in it.
Sure. So it's a big problem, right? And if you just think in the U.S., I'll start in the U.S. About half the U.S. is on a public sector health plan where they're paid. The CMS is reimbursing providers for their care. The challenge is, which we've seen, is that to really showcase or to be able to offer care that is insurance backed, where you can offer, which is essentially affordable to different individuals, you have to show studies to CMS that showcase not just the short-term impact, but the long-term cost savings impact, where they can then reimburse the services large enough where then you can afford to deliver them to people. So we're looking at this as a kind of a journey, not just not just where we are today. So today we have about 92% of commercial lives under contract, meaning if you think about the population of people who are commercially insured, 92% of them can access NOCD therapy as a covered benefit. We're doing research with the commercial population so we can then earn the right to then go and serve folks who are in low-income societies. We're also innovating our delivery of care specifically so that we potentially could serve folks in lower income populations in a more seamless manner. So that's kind of step one. We're thinking about, for instance, different types of digital workbook-like approaches where you can go through a specific set of modules and then message with a provider in a less intensive manner. We're still researching those opportunities. And then long-term, if you think about internationally, we serve outside the U.S. as well. So we serve 3 different countries as a pilot. And in those 3 countries, we've seen outcomes that are very strong. We've offered treatment at a discounted rate so that we could serve those countries and we could learn how to best do it. What we're finding is, to your point, it's very difficult to actually find providers that are offering treatment and they're familiar with ERP therapy, right? So there's a operational process involved with 1, identifying providers in other countries, 2, training them, and 3, working with them over time so they can actually have a good experience and keep deploying services to members. The challenge is, doing that in another country is very different than doing that in the U.S., right? And so we're thinking about that same kind of model where we're offering, digital workbooks mixed with being able to message with a therapist to other countries potentially, given the fact that the data so far looks very strong. We're not yet doing that today, but it's an area of interest for us. And I'm sharing that, openly because I think that the standard models that work here in the U.S., they're really great, but I think there are other models that are also very strong that could be deployed to other populations, and they may not be as effective, but they may be several points less effective, but they're still effective enough and maybe even more scalable, right? So that's better than nothing. And so we're trying to really grapple with how to best do this in a short amount of time, but I'd say just in summary, step 1, we're serving the commercial population, doing studies. Step 2, using the data from the studies to then go in and earn the right to serve the lower income populations. And then while doing that, innovating the treatment approaches such that we can scale treatment more effectively that can be used then globally. So lots of moving pieces here, but it's a definite passion of ours. We want to solve this problem globally.
Great presentation, Stephen. I want to ask you about your business model and how you raised money. So it sounds like you didn't get into the tech stack that you guys have built, but to do something like this at the scale you're talking about requires a lot of tech. It requires a lot of operations. Can you just say a little bit about your funding model and how you guys have been able to raise money?
Sure. So we've raised. Let me step back. So our business model is we're typically a fee-for-service provider. We're like many fee-for-service providers. On the session, we earn margin, and that margin is used then to cover our operating expenses. And so our model has been, first of all, we have a primarily W-2 network. So most of our network therapists, they're full-time employees at NOCD. And we believe that's actually more effective because we can go deeper and we can make sure that the training is really strong. We can ensure that we can manage and supervise on a regular basis. And Dr. Fieser's done a tremendous job of leading that onboarding and management approach. So we have full-time therapists. We earn margin per every hour, and that margin then is used to cover our expenses. What we've done is we've raised capital to scale the size of our network and also to scale our community activation model. So we said, okay, we have all these patients that come to us. NOCD started off as not a network. It started off as a self-help app. If some of you may remember, it was in 2014, people were using the NOCD platform to help do ERP therapy between sessions. And then eventually we had so many people say to us, well, I love this, but I need a therapist. And we're like, well, there aren't many ERP therapists, right? We have to find, I think there's maybe 2,000 therapists in the US for 8.25 million Americans that have OCD. It's at some point in their life. And so we ended up building that network. And so we invest really the venture capital and private equity resources into one, scaling out our community of people who can then access our services, and then two, building up the network and the technology needed to scale care to those individuals. And then as we scale, because of the tech underneath, it can allow us to operate and manage in an increasingly more seamless manner every day, and that leads us to a point where we can then, cover the costs of our care. And at the end of the day, like in reflection over the last decade, what has been the main driver of our business? It's by focusing on the member. Our company value, number one, is members first. Everything that we do is for people who have this issue, OCD. And by taking such an approach, it's allowed us to optimize for all the different nuances that occur throughout the patient journey. And so that's why I think over time we've been able to scale. It's because of just that, like, as a team, that a relentless focus on just the details for each member. And then to provide care in an excellent way, you have to have therapists who are taken care of in a really top-tier manner, and other providers that are care coordinating with us in the ecosystem.
We can probably fit in one more quick question. Last one.
Thank you, Mr. Smith. I was curious about how you go about promoting engagement in the peer support and community aspects of NOCD specifically, and what strategies you employed either in the design of the platform or just in the day-to-day to incentivize people to engage in that.
Yeah, great question. So, we look at the community as being a place where people can connect with others, right? Like when we started NOCD, we didn't actually have the community feed or the community around it. We would acquire people on social media. They'd come into the platform, like many mobile platforms, and they would engage that way. And we had a point in time where we're like, wow, we have great ERP therapy tools to help people between sessions, but the engagement is relatively low. It's like, well, people said, look, I want to learn how to do response prevention between sessions more effectively. I want a way to track my hierarchy in an easier manner. I want to be able to do ERP therapy exercises more easily and see data. So we built all of that, and we were shocked because we were like, why aren't people using it? This is what they're saying they actually want. And as we did more research, we asked the question, if you could snap your fingers and fix 3 things about your OCD, what would you fix and why? And people started listing the things I just described. And then through that process, though, our users were commenting within the question back and forth. It was on social media, and they were liking each other's comments, and they were commenting on the comments, and it was just like this very engaging approach. And so we realized, wow, if we go and we put the community actually within the platform, people will come back to ask questions about their OCD or to reply to someone else in need and feel that support. And then from that point on, they'll use the digital tools that can help them. And so it's a really like peer-to-peer focused engagement model that has worked. And so what we did over time is we saw that as we had that unlock, we started to then test how to best connect people to others like themselves in a more personalized manner. And we have different machine learning algorithms running in the background to detect if people are asking questions for reassurance. We can educate them in that moment too, that look, this is actually counterproductive for your treatment. If you want to learn how to do treatment, you can go see someone who is specially trained in treating OCD, or maybe even see one of our preferred partner providers that are prescribing medication if they're looking to take SSRIs. And so it's given us a way to, that community was really let me rephrase this. The unlock was the peer-to-peer connection, and then what we did was we used technology to foster that peer-to-peer connection, more effectively over time. Yeah.
Thank you so much. Yeah, great. Thank you.
Yeah.